All right, this is part one in the healing process lecture, and I thought we'd start off with a case study so you can kind of get an idea of why we want to know this material and kind of what we're looking at. So our case study is that 2 days ago, Jordan was playing Ultimate Frisbee and hyperextended his knee, resulting in a torn ACL and MCL injury. So the questions that we want to know related to this course or to be able to answer are what exercises can he start doing? This injury occurred 2 days ago. Can he start anything? Then what are the first goals that he needs to reach? What would we tell him is most important? When can he progress his exercises? And if we go really long term, what must he be able to do before he can return to Ultimate Frisbee? There's a little link up here if you want to watch a clip of an Ultimate Frisbee injury to the ACL MCL take place. So you can get an actual movie of this occurring. Although it's not Jordan, it's a different athlete, but it might be kind of fun for you to watch. So today, as we talk about injuries, we're going to look at primary and secondary healing and what takes place in these events. So our tissue healing phases, we actually break them down into 3 phases just in order to understand them. So the inflammation, the proliferation, the remodeling phases. But they overlap quite a bit, the events in these phases. So we'll have activities that we actually put in the proliferation phase that are starting maybe in day 3, which we actually say is part of the inflammatory phase. So these phases, the activities overlap. They aren't as clear cut as we're going to make it seem in the lecture. When an injury occurs, the immediate response typically is we have some disruption of the blood vessels. There's an immediate vasoconstriction to reduce the amount of blood loss, and after that, might be 10 minutes, we start to have vasodilation because we need to start having chemicals and cells brought in that help with the response to the injury. So we'll have blood come in, serum proteins, clotting factors, and platelets. And as you can see, it just starts a whole cascade of activity. So if we follow one of these branches down, platelets come in and they cause a chemotaxis effect, which means they're going to cause a release of growth factors and fibrinogen and fibronectin. And we can follow one of these down, these branches down, so that we look at growth factors. And when we have more growth factors, which is a protein release, then we have more cell migration, promotion into the wound. So we have a whole cascading effect of events that take place. And I'm not asking you to be able to reproduce this table. I just want you to see the complexity of what can be taking place. And we really understand a small amount of what's probably taking place. What we do understand will help us guide the exercises that we're going to prescribe. So as we look at these phases, and on your outline, if you could follow along in the notes today, I really want you to make sure that you write down the material that is written in blue. That's the stuff that I want you to pay special attention to. So in phase 1, which is called the inflammation or inflammatory phase, the duration is about 3 to 5 days post-injury. In this phase, we have complex chemical and cellular interactions occurring. This is a necessary phase, so we don't want to ignore it. We don't want to have it completely gone, but it should not be prolonged. So we want to make sure that we provide the ultimate environment for it to heal. So that ultimate environment would be rest, ice, compression, elevation, and all these together help to minimize and contain the damage. The modalities, the goal for those are to increase blood flow and decrease pain and spasm. But again, I want you to remember that the duration is 3 to 5 days. Cellular reactions or what's taking place, kind of, this is written under the hallmarks. These things absolutely are necessary. We have clotting that takes place. The platelets bind to the collagen stumps that are left from the injury. Our platelets release the fibronectin. It's just an automatic response with injury, and that fibronectin binds with fibrin and collagen, which produce a fibrin plug, which is kind of the very first part of a scar or a scab taking place. We kind of got this thicker cross-linked tissue slowing down the bleeding. Once this is stable, the fibrinolysin dissolves the fibrin so that the lymph can drain, and then later the plug is replaced by type 3 collagen. Again, the most important information is written in blue. The black is just to help kind of fill in the gaps in your understanding. Another hallmark in this phase is with the occurrence of polymorphonuclear neutrophils, which are white blood cells. They're seen about 5 to 6 hours post the injury, and they come in great numbers. They have a very short lifespan. Their job is to destroy dead tissue and debris. So they're first in, they work fast. As time goes by, they're replaced by mononuclear phagocytes in about 24 to 48 hours. So here we have a picture of the cells coming in, the white blood cells, the PMNs coming in and starting to help with the fibrin plug of events. And then the last one is what's called chemotaxis. Chemotaxis is the attraction or production of cells through chemical stimulation. The little taxi is there because this word reminds me of a taxi going out and getting chemicals and transporting them back into the injury site so that we can have the initial phases of reactions to inflammation beginning. An example of this would be like histamine, and histamine causes an increase in vascular permeability. So when we have a disruption of the platelets, histamine is released, and also the presence of polymorphonuclear neutrophils to draw the leukocytes, and which are red blood cells, to the area, and that takes place via chemotaxis. This is then replaced by the kinins. So that's an example of what might happen in chemotaxis reactions. The signs of the inflammatory phase, we have 5 cardinal signs. So typically we'll see some edema, some redness, increased temperature, there's pain that the patient will report, and reduced function in this phase. Here's a fairly graphic picture of an incision that's only 10 minutes old. So we see all of these things in this picture. Later on, as the wound heals, this is still in the inflammatory stage of healing, but it's later. And we have discoloration of the borders of the wound and slight swelling around the wound edges. So some visuals on that. Results of prolonged inflammation. So what if we don't address this inflammatory stage? What if we just let it go, let the person continue to walk? The inflammation continues to go on. These are the things that can happen. Synovitis, which is an inflammation of the synovial lining of the joint. And when we have synovitis, it can result in damage to the joint capsule, which is a sleeve around a synovial joint. So we might have tears in the joint capsule, we might have adhesions in the joint capsule, all of which limit range of motion, due either to pain or actual structural limitations. And then we could continue to have degradation of the articular cartilage. So somebody that has prolonged effusion of a joint, they may say, well, who cares? I can live with inflammation of this joint. These are the reasons that we don't want a joint to be chronically inflamed. It may cause degradation of the articular cartilage, which means they're going to have an early arthritic changes. So what are some activities that we can do in phase 1 of rehab? Well, our primary goal is to control the edema, the swelling, and pain. So we use modalities for this. The rest, ice compression, elevation. There's other modalities that we might use. We can start some stretching because we can provide limited tissue stress, not to the point of pain, what they can tolerate. Certainly maintaining cardiovascular fitness, and then avoid strengthening activities. We aren't going to have them do a lot of loaded range of motion. So we might use a CPM, which is a continuous passive motion machine. It's pictured over here to the right. Gentle range of motion can be used. Either somebody can provide that, or we can hook them up to an isokinetic machine, which is this picture down on the bottom right. And we can maybe start some light isometric so the joint isn't moving, but we're getting a contraction at that joint. And we'll talk about those as we get into the strengthening section of this course. Duration factors, is that right? Yeah, duration factors. I don't know, when people say how long is this going to last, it all depends on the size of the injury, the site of the injury, the tissue type involved. There's a lot of variables, but it may take 2 to 4 weeks before we feel like we're moving into the next phase, which is proliferation. So hallmarks of this phase, and these are written down in your notes. Fibroblasts primarily present 3 to 5 days post-injury, so add that in there. Polymorphonuclear neutrophils, the PMNs, are almost non-existent. They've pretty much done their work. They've come in, taken out the initial dead tissue and debris, and are now removing themselves from the site. We have new blood vessel formation, which is taking place. This is also called angiogenesis. And new granulation tissue, which is beginning to form. So here we have a little cartoony picture of new capillary buds starting to move into the area. So we have actually capillaries that will grow into an injured area, supply the oxygen. When they're no longer needed, they start to retract or close up. One of the things that is a hallmark in this is a growth factor, and we see the presence of growth factors, which are proteins that serve many functions, but the primary one that we're interested in is that it promotes healing. We've seen some evidence that it affects the fibrin plug formation. It can promote angiogenesis, stimulates type 3 collagen degradation, which is a weak collagen, and it encourages new cell formation. There's different kinds of growth factors. There's some examples written here. You don't have to know the specifics, but it's important that these are present microscopically in order to promote the healing, supervise the cell growth, the division. The growth factors are actually receptors specified, so they aren't going to work on every cell, so certain growth factors only work on certain cells. And that's my point of this picture. So we've got a growth factor here with a certain receptor that is only going to work on these purplish like cells that will only connect into certain receptors. So they aren't universally able to work on every cell in the body. In this phase, we've talked about collagen as type 3. Collagen of type 3 is usually seen about 48 to 72 hours post the injury. They're really weak and thin fibers. They've come in just to try to do quick damage control. They're laid down really haphazardly. And eventually they're going to be replaced by type 1 collagen fibers, which are much stronger. Tensile strength in this phase of proliferation, again, is provided by the collagen and proportional to the amount, type, and arrangement of the collagen. By day 7 post-injury, on average, there's a significant amount of type 3, which is, again, a weak type of collagen. But at day 12, that type 3 collagen begins to be replaced by type 1 collagen. And so we have a thicker collagen, which would indicate that we are able to start more activities. What are the signs that we might see physically in this stage? Swelling, fluid in the area, redness because we have new capillaries coming in there, and then sensation. They're pressure-sensitive nerves and tension-sensitive nerves tend to be a little hypersensitive in this phase of healing. So here we have a little cartoon graph of we've got some angiogenesis taking place, we've got the capillary buds completed. We could pretend these are growth factors, these little ones around here, to help us remember that we need the presence of this protein in this phase. Here's a picture, an actual picture of a wound that's in second stage or proliferation stage. We've got that red granulation tissue right here over the muscle that is showing some good healing. Here's another picture in this phase. Again, this is a pretty good picture of the granulation tissue that you'll see. What can we do in phase 2 for exercises? Well, We can start a little more aggressive range of motion. We're going to talk about mobilizations, and we grade these 1 and 2 mobilizations. They're fairly minimal. They're just to reduce pain. So we'll work on those early. Grade 3 and 4 joint play mobilizations will begin a little bit later. We can do some strengthening. Certainly if we haven't started isometrics, we will start isometrics unless it's a tendon repair. Tendon repairs will have to wait a little longer because if we contract them too hard, the tendon can actually rip through the repair. Cardiovascular conditioning should be well on its way, and proprioceptive training is going to begin as well. Phase 3 is the remodeling phase. This is our last phase where we see collagen transition having taken place. The type 1 is synthesized. The type 3 collagen has all been destroyed. This could take as long as 6 to 18 months. It's not a quick process. So just keep in mind that if somebody has a torn ACL, torn MCL, and they're taking or they've gone through rehab and they're going back on the field at 6 months, that collagen around the injury is kind of still young. It's baby type 1 collagen. So while it's strong, it still could be up to a year before that collagen is really at its best. The area becomes more stable with permanent cells and structure as well. The wound contraction occurs if there is an outside wound, seen at 5 days to 2 months. So we have a little bit of difference depending on if the wound is visible. Contraction reduces the size of the scar as it begins to heal, which can be good and bad. Certainly a reduction of scar size is good on the skin. However, if we aren't moving the joint and it's an internal contraction or scar tissue, we can end up limiting the joint range of motion. In this phase, we'll also see a decrease in capillary numbers. Again, we have a better blood supply. These capillaries aren't needed. Decrease in fibroblasts and myofibroblasts. That activity has already taken place in phase 2. So here's our injured site. We have fewer growth factors in this site. We have a retraction of the capillaries as they aren't needed as much. Here's a visual of this. It's a burn, and we have some little scar tissue here in that raised area, and some contraction of the skin kind of around it. What exercises could we be doing? Well, any exercises that will increase tensile strength by a stress application. This is Wolff's Law. So we're going to start increasing loads on muscles, tendons, bones, and ligaments in this phase. A little point about chronic inflammation. This is different than our phase 3 inflammation. So we'll talk about like chronic inflammation of the Achilles tendon, or maybe further up in shin splints, we'll see it in the posterior tibialis. But what is this all about? What's going on here in chronic inflammation? Chronic inflammation is considered, it's not the same as somebody going out and repetitively injuring. So they aren't continuing to go out and like stubbing their toe over and over and over, or spraining their MCL over and over and over. The chronic inflammation is caused by an inability for the body to move from the inflammatory phase into the proliferation phase. We don't see the same cellular responses taking place. It's just kind of stuck in this phase 1 of healing and we can't get it out. Recently, the research is speculating that it might be due to a lack of the proper growth factors that are needed in order to promote the continued healing. So we'll treat chronic inflammation a little bit different. So I just wanted to make that a point in this phase. We'll treat it more like actually a phase 1 injury than anything else. So back to our question, our case study with our torn ACL and MCL, and let's assume he's not going to get this repaired, all right? These don't have to be repaired ligaments, and we'll assume that he's not going to have the surgery. So I'd like you to write down on a piece of paper, in general, what exercises could he start doing? You don't have to know specifics about how much range of motion he has or his strength, but in general, go back and look at the phases of healing, and what exercises did we say could start to be done in, say, 2 days post-injury to a ligament. When can he start doing them? Again, we're at day 2. Can he start them now, or does he have to wait to start his first exercises? What's the first goal that you want to see be reached? We talked about different landmarks or goals in progressive rehab in our previous lecture. So what goals might you want to see? When can he progress his exercises? How do you know if he's ready to progress his exercises? And what needs to be able to what do we need to see him be able to perform before he can return to ultimate frisbee? And again, that was probably information that would be more easily found in the previous lecture. So write those out on a piece of paper. We're going to start lecture talking about these, and we won't repeat any of the information that was on this. So we'll see you on Thursday with your bring your outlines in case you have any questions or need to refer to these during the lecture. But we're going to start with this, answering this, and then talking about healing by tissue type for Thursday. So have a great day.